We present a case of drug-induced interstitial lung disease secondary to tyrosine kinase inhibitor. We had a patient, 82-year-old male, with past medical history of lung carcinoma, stage 4 adenocarcinoma, recently diagnosed with metastasis to liver and pancreas, who had been on osimertinib since 8 months, presented with chief complaint of shortness of breath. Shortness of breath was progressive since 1 week. He was not able to go to the restroom without being out of breath. When he presented to the emergency department, he was desaturating to 80%, requiring non-invasive ventilation. He was kept on BiPAP in the ED itself. His lab workup revealed an arterial blood gas of pH 7.44, PO2 66, PCO2 33.5, consistent with respiratory alkalosis and hypoxemia. His complete blood count had leukocyte within range, hemoglobin was low 9.6, microcytic normochromic, CMP was within range except for sodium with a level of 123. His echocardiogram had ejection fraction of 60 to 65% with mild concentric left ventricular hypertrophy. Chest X-ray done in the ED itself revealed bilateral diffuse airspace opacity that was noted throughout the lung, more on the right than the left. He also had a CT chest done, which revealed diffuse bilateral ground glass opacity with more consolidative airspace opacity in the lower lobes and right middle lobe. This was concerning for acute respiratory failure secondary to either infection or heart failure or complication from the carcinoma or a complication due to the medication that he has been. The clinical course consisted of him being admitted to intensive care unit for acute respiratory failure and was started on empirical antibiotic. His lab worker also had high D-dimer, and with the carcinoma, pulmonary embolism was ruled out with a CT angiogram, which also helped us to realize the bilateral ground glass opacity and the location of the consolidation. He had bronchoalveolar lavage done to rule out infection. His bronchoalveolar lavage did not reveal any eosinophilia or increased leukocytes, or stain was negative for any bacteria, fungi, as well as culture was negative. These helped us rule out infectious etiology of bilateral infiltration. We then had him on IV methylprednisolone to cover up for either organizing pneumonia or drug-induced pneumonitis. Patient continued to deteriorate as he continued to require BiPAP for a prolonged period of time, to the point where he needed invasive ventilation. There was a discussion done with the family and the patient. Patient was decisional as well, and he opted for comfort care, and he went for hospice as inpatient, and unfortunately he did pass away within few days. To the discussion part, tyrosine kinase inhibitor is a new era for treatment of lung carcinoma. It is given for patients with non-small cell lung carcinoma with positive EGFR with mutation. Diagnosis should be done with imaging modality, exclusion, and diagnostic modality. Treatment includes discontinuation, steroid therapy, and some case reports of rechallenge exists. In conclusion, TK have been new era of treatment, and there should be more studies done regarding the side effects as well as by treatment options. Hence, we need more studies to be done. This case report also re-emphasize on this. Thank you.